Good afternoon. Okay, can you hear me? Nazar can hear. Can, okay, I proceed. I was given task to do wood construction, CCC and hydrodissection. But I think it's the best is to actually to deliver this lecture in videos. But I have some text to share with you. Next, this one. Okay, this is my financial closure. Okay, I just have to show you this slide. You will make yourself better by subjecting yourself to monitoring. As you can see, our patient comes from patient recruitment to visual outcome. Unless you sit inside here and monitor your indicators, for example, your PCR, how you perform your visual outcome, then only you become better. If you just do yourself alone without people monitoring, then you will not reflect and you will not see your achievement. These are the indicators from pre-op, intra-op, post-op. And this is what I hold on until now. When you come to us, right, you actually teach, learn to teach to learn. You come to us to learn how to teach. And when you have already done your Phacos, you know what, I mean, you're well versed with your Phaco. You have to teach in order for you to learn. And when the trainees come to us, they come with variations, you see, and your colleagues have variation, but you have to accommodate them. For example, the easiest example is when they do CCC, right or left. For example, you don't undo them. You let them grow, and they will think for themselves and choose, and do narrative surgery and recording. So steps in Phaco surgery, they're all dependent on each other. Wound, CCC, hydrodissection, scalp, and you have to do the best wound in order for you to have the best Phaco, I suppose. They're all dependent on each other. Yeah, that's I think by now you understand this. And it's either your site position, length or shape, scleral, limber or corneal position, main wound, superior temporal. These are the types of wound that you have. And this is I think Nazra has mentioned about this early on. And I just understand that, you know, I can point, okay, you know, you call this 15 degree because, you know, when you draw a line across line straight there, right? This is actually 15 degree. There's also 0 degree blade, but I rarely use this. That's why I just come to know about this today. All right. So thanks, Nazra. This is done already. And you know, when your blade is sharp and not sharp, it's because of this microscopic appearance of your blades. So some people complain, this is sharp, and they don't like this not sharp blades, and they throw it away. They want money blades only. This is why it is. And this is the cornea incision. It's about 1.5 millimeter. Scleral very rarely used. I don't do my wound starting from sclera. So it's all clear corneal incision. And this is what clear corneal incision should be started, and wrong incision when it is initiated up there. Okay? And I just scanned this morning. I couldn't find, the picture showing this flaps. So I'll draw it and scan it and put it in the PDF. So a single plane. This is just a single. This is what actually happened to when your blade is too sharp. You just go in and out, without the proper construction. I normally do 2 steps, 2 planes. So you just go in and create a striate and go straight. And the other one is the 3 plane. When you have certain surgeons, many surgeons, they will do incision first. They use 15 degree blade. Use vertical incision on the limbus, and in order to get the first plane, and second one in the cornea, and the third one inside. So that's the 3 planes. But the problem with 3 plane wound is when the first incision heal, right, it can actually give scar. There's a wound there. There's this uneasy edge. The patient can actually feel it, some foreign body sensation. I prefer the middle one. And it comes I'm going to show you videos afterwards. So these are the issues. Among all the years of training your colleagues and learning and sharing, this is the common issues that we have in wound as far as Phaco is concerned. Sharp versus not sharp. What do you mean by sharp? And having a sharp blade doesn't mean anything if you don't create your wound properly. And I actually don't prefer the too sharp wound because you end up in one plane only. So I prefer the blade which will give resistance so that I can give that 2 planes or 3 planes. And the first wound, whether you want to do main wound first or side port first, you should have the reason why you should do side port first, why you do main wound first. And mostly they will say AC will collapse after creating main wound. And why should it collapse? I'll show the videos afterwards. It shouldn't collapse. If the wound is collapsed after you create the main wound, that means you're actually pressing the wound. That shouldn't happen. And when you actually do your blade, use second port first, meaning it has become blunt. It has been used for your second port. It's blunt that you use for your main wound. Then theoretically, it should be blunt. It should be a blunt blade. So it should be used for the main wound instead of second port. Alright. And which blade do you use for main port? Which blade do you use for second port? I use both at the same time. There are reasons behind that. I'll show you in the videos. And there's no point doing the best wound when you are actually messing up with the wound. For example, too frequent in-out instrument. You're so anxious. You're not sure you in-out, and your supervisor took over and all those. And when your instrument is in, you're actually not aligning it centrally. You're aligned, singing all this way, dragging your wound. And the worst would be when you're actually performing Phaco near the wound. You have to check your setting. When your Phaco is too high, the power is too high, it can cause corneal burn. And there's no point having good wound when all this is not be taken care of, right? Taken care of. And leaking, what do you do with the leaking? Do you pad, dye, do you suture, or use bandage, contact lens? This is what you have to think about. Stroma hydration, which one to hydrate first? I will normally do second port first. Second port hydrate, and main wound, I don't normally hydrate. Some do hydrate both wounds. And CCC, so complete circle, you shouldn't leave tags or you shouldn't leave weak points there. Direction of pull, each pull is all towards the center. Size, you always ask how big is your optic. The optic standard size is what? That size, so it's 0.1 to 1 millimeter less than the optic size. If it's too large, optic capture, too small, if you get some removal. These CCC issues we have from our trainees, even ourselves, turn right or turn left, it doesn't matter. As long as you complete the CCC. And most importantly, you don't undo people, right? Stain versus no stain, you give vision blue or no vision blue, there's a big issue for me. So you have to, like when you have the highest end microscope, right? The highest end machine, you can actually see this capsule well. So why do you need to stain? Because staining, it comes with complication as well. Sometimes you accidentally stain the endothelium, the descemet layer, the descemet pocket. If it's not unnecessary, you don't put it into the eye. And what to mention about contamination of drugs, all those vision blue, right? So we want to avoid that. If it's unnecessary, you don't need to. Dense cataract, why you create small CCC in dense cataract? It's because you're anxious. Because you're anxious, you're afraid that it may run. So you're pulling it too early. So you end up in small CCC. And whether you need to aspirate cortex in dense cataract. Not all dense cataract you need to actually aspirate the cortex, only in tumescent cataract. But even in tumescent cataract, I rarely aspirate the cortex. You do normal CCC, but press the cortex or the nucleus down when you do CCC. This is hydrodissection. Where to hydrodissect, how much to hydrodissect, all the issues. And I think the only way to learn this is by watching video, by doing and watching video. theoretically you may understand, but you understand better by watching video. How much to dissect? Do I need to evacuate OVD? Some surgeons, they actually press the wound to evacuate OVD, come out, all OVD come out before they inject. It's actually unnecessary. You can actually inject through the capsule, in between the capsule, lift up the capsule, lift up the wound, and inject. So everything will come out, okay? So dense cataract or high cataract, is it necessary to hydrodissect? It's not necessary. Okay? When you have white cataract, hard, malignant, or you just want to mildly do the mild hydrodissection, you don't need to pull it, push it hard. So hydrodissection, when you have a small CCC, how much you hydrodissect? You have to be gentle. You know what happens if your small CCC, when you push against a close eye, AC, the PC will give way. So you have nucleus drop. This is easier to demonstrate. Okay? I've edited this video to just show until hydrodissection. So I use 2.75. See the way I hold the eye. So there's some surgeon, they hold opposite using cotton bud. I don't say it's wrong. I never say any technique is wrong. So normally when trainees come to me, I would just say choose between the two, which one you're okay with. And I will just explain to them that the justification of the steps or behind this, and they choose themselves. Right? And this is how I do. I hold it there to stabilize the eye. So it's 2 steps. This is all topical only, right? So it's the same. I use, see the way it goes in. You just need to slide in it. You don't need to struggle with this one. Okay? The same blade, you put it in, you just see the tip. The reason why I don't use 15 degree is because I need the range, you know, your 2.75 is big. So when I'm active with my left hand, so that it gives me the angle of movement without creating striae in the cornea, without dragging the wound. Okay? So this is what 2.75 blade gives you. Right? So this OVD, you put it in right away to the center so that you will distribute properly. This is, I don't use bend needle. I use the sharp end of the Utrata to do CCC. No vision blue. You can see the cortex. The capsule clearly. So I want to show you this, how I teach my trainees. You see the wound, whether you want to know whether you are dragging the wound or not dragging the wound, whether you have striae there or not, corneal striae. So don't create striae when you create CCC. Then you will get perfectly round CCC. See, there's no striae around. Okay, for hydrodissection, 2 places only, 3 o'clock and 9 o'clock and 3 o'clock. You lift up the whole thing. So OVD will just come out, okay? BSS will come out. So that's it. Second video clearer. So sometimes you are not that lucky to get, sometimes not that clear your cataract, your view of capsule. So it's the same thing. Sometimes we get this blunt blade. So just do it. It's just okay, isn't it? Okay. All right. So it's the same thing. So if it is blunt, what do you do? This is what you do. Okay, that's it. Okay. Same thing. So when people use a bend needle, I don't say it's wrong. I don't say to my trainees, please undo that. Follow whatever I say. Right? I don't do that. I don't undo them. Let them do whatever, but I grow them, I will groom them from whatever they have, right? So groom them until they understand why, and then automatically they will just do this with Utrata. So it's a vertical, it's actually you are tearing it down, get the flap. So sometimes you are not that lucky to get, sometimes the view is not good, you know, because of the CCC. But you can still see it. So the direction of pull is all towards the center. So you see the wound, if you have striation, right? Striation meaning you're not positioning yourself correctly, so you reposition yourself. All pull towards the center. There's no issue about your CCC running to periphery. Right, done. Hydrodisection. This one I do more because of, I suspect the adhesions there. I do in few places. And you don't see the waves, right? Because of the PCC. Okay. Done. Okay. All right. This one you need vision blue, okay, for sure. Dense cataract, intumescent cataract. Okay? So it's the same thing, it's routine. So you hold with your cotton bud. Two steps wound. If you want to do 3 steps also, okay. Little, right? You just slide it in. So it's done. So you put vision blue. You wash it out, okay. OVD. This is Pseudo X, right? Pseudo X capsule. So with this intumescent cataract, mostly people would just insert needle in, aspirate. How much can you aspirate? We don't know. And whether you're actually the cortex is, you can actually aspirate that or not. We don't know. And probably it's too intumescent. The act of putting the needle in will completely tear the capsule because it's so tense. So what do I do? Utrata, like usual. So you turn it immediately. You turn. You don't leave it vertical. You don't leave it straight. Eh? If it's really intumescent, you can actually press the nucleus down. Okay? Okay, done. So hydrodissect or no hydrodissect, you probably can do minimal hydrodissection. So you see the OVD come out by itself, right? So then you can start your Phaco. So I think it's my last video. Sorry, no, it's not my last. Okay, let's see what we have. Okay, oh, okay. It's done my training. I erased the name. Okay, the same wound. Okay, see the striation. All right. So see properly. Oh, can you see the video? Is it running? Okay. Hold on. Can you see the videos? Okay. It's lagging. Nazrah nampak video? Is it running? Is it running? Okay, I want you to see the second part. Okay, this main wound. So this is the second part. First of all, it's two anterior. Brilliant. This is two anterior. Okay, struggle, pressing, struggle. And took too long. So patient look up. So you end up having a big wound. Could you all see? It's a big wound, as big as 2.75 wound. So what do you do in this type of surgery? You create another wound. You ask for 15 degree, you create another wound. You don't use that wound for your second part. This is my last video. No, sorry, this is not yet. Okay, what happened if you create two big wounds? So your iris prolapse through the wound. Okay, so that's what you do. Okay. Okay, this is interesting. Done by one of my trainees. Okay, look at it. Main wound. Look at it. Okay, properly. Pressing. Can you see it's pressing the wound? Okay, gush of fluid come out. Probably repeat. Okay. When you are so anxious, right? So anxious, you're nervous, you're doing it, you actually tend to press. It's actually the same thing when your trainer said you're actually pushing the eyeball down, right? It's because you're pressing your Phaco probe onto the wound and do your Phaco. That's why it's rotated down. It's the same as wound when you're pressing it. So this is the reason why people say, oh, I don't want to do main wound. They say the AC is collapse when they create the first wound because it's pressing the wound. So first few videos you actually see, and it's actually possible to do wound without collapsing the AC. Look at it again. Okay. Okay. Again. Again. You see gush of fluid come out. Is it clear? Is that clear? Nazra, can you respond? Is it clear? Okay. Ada lagging. Again, try again. Okay, press the word. So you see collapse. So what do you do? OVD. Okay, you see afterwards. OVD first. Okay, it's a reflex response. So we need to form the AC in order for him to do the second part. Okay, it's correct lah. It's correct, but it's not OVD. Okay. Okay, second part. Okay, second part. So you're so into this, you're so obsessed with this until you forgot something. Okay, done. Wound done. So vision blue kan? What happened to vision blue? Because it's OVD. So the step is not correct. Okay? So you don't get obsessed with this one so much. So in order for you to have this staining working, so you have to take out the OVD. So see the difference. All right, I think that's my last video. So good surgeon, just to summarize, we will be seeing a lot more tomorrow. Wound hydrodissection, CCC. When you see the videos, a lot of videos, you can learn from the videos, not from the books or the lectures. You learn from doing, you learn from doing. Good surgeon, you can see beyond cataract. It's beyond it. There's so many things beyond cataract. You cannot just see a patient, a cataract. You have to see patient. For example, when you do surgery, I always ask my trainees, have you told the patient the steps? You talk to patient. Have you talk to patient when you insert IOL, for example, it's painful, so you have to tell the patient. So you have to communicate. You don't know what happened beyond the drapes, and you see beyond cataract. You see the families. You see who brings them in and all those. And you don't choose patient, and this is how you learn. You don't choose your patient, hard patient, complicated patient, you give to your seniors, you give to your consultants. You do it yourself. Your consultant will sit with you and do. And the way I do cataract surgeries, I don't change so much of setting. My setting works only one. What works is your foot pedal control, most of the time. For the exception of high myopes. Sometimes I change, but most of the time I don't. And foot pedal control must be excellent. The idea of this is foot pedal control, left hand control. These two things, and you can do Phaco well. And no machine preference. You give any machine you can do. That means you are enough. You understand this Phaco concept very well. When we give Stellaris Elite to you, you can do. You give Stellaris, you can do. You give Centurion, Infinity, anything. Small machine, big machine doesn't mean anything. And no surgical equipment preference. That's how to do. That's how to become a good surgeon. And no IOL preference, definitely. So I end my lecture here. Thank you. Any question?